Hello, this is Dr. Bhomik, and as I mentioned in my last presentation that at next entry I am going to discuss more pediatric board review questions and their answer and bit explanation. And today we are going to discuss quite a few important question and answer session, which is a very favorite pediatric endocrine part of the board examination. My first part is going to be related to diabetes and then other subject. The first question I'm going to start with: what percentage of beta cells are destroyed before the clinical symptomatology of diabetes mellitus? Is it 20%? Is it 40%? Is it 60%? Is it 80% or 100%? Now this is well known that when a patient has developed classical symptoms of diabetes mellitus, probably 90% of the beta cells are destroyed. So in this case, the best scenario and the answer will be 80%. Question number 2. Which of the following is a false statement regarding epidemiology and pathogenesis of type 1 diabetes? A. Even with increased pediatric obesity, type 1 diabetes remain the most important cause of diabetes in childhood. The B is most common type 1 diabetes has positive, most patient with type 1 diabetes has positive family history of type 1 diabetes. C, not all symptomatic individuals with measurable antibody against the beta cell will develop type 1 diabetes. D, the risk of type 1 diabetes linked to the HLA complex system. Here the answer will be A. So we do know and we are concerned about the increase of type 2 diabetes, especially in the adolescent, but at the end of the day, it is still the type 1 diabetes is the most common form of diabetes in children. It's about 1 in 400. So correct answer will be A. Ideal time to start fast-acting insulin in DKA management. After first hour of fluid therapy, after the third hour of fluid therapy, or at the same time fluid and insulin together, or when the blood glucose is greater than 400 or so. The correct answer is after the first hours of fluid therapy. Always remember that it is the rehydration is very important. Fluid resuscitation always precedes the insulin therapy. So in about after an hour of fluid resuscitation, one should start insulin. Insulin is given by intravenous drip. Question number 4. Most death in children during the DKA management is due to A. Cardiac arrhythmias, B. Cerebral edema, C. Hyponatremic seizure, D. Hypoglycemia, E. Renal failure. Clearly the answer is cerebral edema, and that is why the pediatric endocrinologist as well as internal PICU intensivist, PICU physician are always careful and making sure they are checking the vital signs and neurological signs only. And in pediatric, the fluid management has been conservative, and that is because of the fear of cerebral edema. In my lecture with DKA management made easy, I have mentioned this one a little bit more elaborately. Although cardiac arrhythmia, hypoglycemia, renal failure, hyponatremia, they all can occur, but the cerebral edema is the leading cause of death in children during the management of DKA. In relation of stopping IV insulin infusion, the first dose of subcutaneous insulin should be given 30 minutes before, 1 hour before, 30 minutes after stopping the IV insulin, or 1 hour after stopping the IV insulin. Most of the endocrinologists or PICU specialists will like to give a sub-Q insulin 30 minutes before they stop IV insulin drip. So there is a lag period, and that is like it takes about 30 minutes for sub-Q insulin to catch up. That's why most of the people will prefer 30 minutes before. So correct answer here is A. Next question. Which metabolic derangement is potential complication due to insulin therapy for diabetic ketoacidosis? A. Hyperchloremia, B. Hyperkalemia, C. Hypernatremia, D. Hypokalemia, and E. Hyponatremia. The answer here is D. We know that a child or a pediatric patient when present with DKA already have significant amount of potassium deficiency. The hydrogen ion or acid ion has gone inside the cell as a buffering mechanism, and potassium comes out. So most of the scenario, when you check the blood electrolyte, you will see the potassium level is high, and that is what we call pseudo hypernatremia. Since most of the potassium in our body is inside the cell, but when you do the blood test, it measures the potassium in blood, in serum. So therefore that does not reflect the total potassium in the body. So once we give fluid, that pushes the potassium through the kidney, but mostly the insulin, what that will do, push back the potassium inside the cell, and the hydrogen ion comes out. And as a result of that, there is a significant danger of hypokalemia if one is not following the electrolyte carefully. So the answer is D. The endocrine cause of delayed puberty include all of the following except hypothyroidism, Crohn's disease, poorly controlled diabetes mellitus, glucocorticoid excess. This is a little bit trick question because the question said this endocrine cause. So the one which is not an endocrine disease per se is Crohn's disease, although it is associated with growth failure as well as delayed puberty. So here the correct answer is Crohn's disease, and other three that I have put there, they are known, they are endocrine cause known to delay the puberty. Question 8. Which of the statement is not true regarding the complete androgen insensitivity syndrome? The old name, and still many older physicians prefer testicular feminization syndrome, TFS. They are A. phenotypically female, B. the mechanism of genetic transmission is X-linked dominant, C. karyotype 46XY, D. gonad secretes testosterone, E. the target organ do not respond to the testosterone or dihydrotestosterone. The correct answer is B. The false one statement is B. The TFS is X-linked recessive, not dominant. And I will explain this condition in my future lecture of male pseudohermaphroditism or testicular feminization syndrome lecture. Question 9. Which of the following is true regarding the primary hypogonadism? So, primary hypogonadism where the primary organ is at fault. So, should they have high FSH, LH with low testosterone in male and low estradiol in female? B. FSH, LH is high but the gonad is insensitive to both hormone. C. Family history is rather common in many cases. And D is karyotype is almost always of sex appropriate. The answer is A. Since it is a primary hypogonadism, so FSH LH will be high to stimulate the primary organ, testes in case of male and ovary in case of female, and since there is a problem there, it will fail to increase the testosterone level in male and estradiol in female. So therefore the correct answer is A. The clinical features of vitamin D deficiency ricket in infancy. In infancy includes all of the following except A. failure to thrive, B. bowing of the leg, C. bone pain, and D. myopathy. Now this is the one, if you are not careful, you are likely to make mistake, because when somebody is talking about rickets, the first thing comes in the mind is that the bowing of the legs, bow leg, rickets. However, that only happens when the child has started working or supporting the body weight, and otherwise there will be no bowing of the leg. So bowing of the leg only occurs when there is the body, when the patient or the child or infant is working. So bowing of the leg is the wrong answer in this case. Question 11. Which of the statement is not true regarding nephrogenic diabetes insipidus? Electrolyte findings are similar as central DI. It is autosomal recessive disorder. Renal tubular unresponsive to ADAs. Episodic hypernatremic dehydration may be a problem in management. The answer is B. It is not an autosomal recessive disorder, it is X-linked. That's why most of the patients are male. Excellent. And the other statements are true. Episodic hypernatremia, relatively unresponsive to the ADAs, and that's what it is also known as ADAs resistant uh, uh, diabetes insipidus. Question 12. Marfan syndrome. Finding includes all of the following except it is a connective tissue disorder. Ectopial lentis syndrome is common, either anterior or posterior dislocation. Aortic aneurysm and the mitral regurgitation is the most common cardiac defect, and it is X-linked recessive disorder. The wrong answer is D. It is not X-linked. Most of the connective tissue disorder or anything related to the bone or cartilage is autosomal dominant. So, Marfan syndrome I have discussed more elaborately in my lecture for the evaluation of tall stature children. So I would recommend that if you read the tall stature evaluation of in the lecture series, and you will have even more or further information regarding this Marfan syndrome. I wanted to show you this X-ray. Is a very important X-ray, and here what do you see? Okay, the most important finding here is cupping and the flaring of the epiphysis, and this is the classical finding in vitamin D deficiency rickets, and this kind of X-ray picture or X-ray radiological picture may be given in your examination. So radiological, this is not a multiple epiphyseal dysplasia, which is extremely rare, and there is the genesis of the epiphysis is a very common finding, and that is not the case here. And significant bone loss, you don't see it. There is a periosteal reaction and questionable bowing of the leg, and which if the patient is not walking, that's probably of no significance here. Here is a question is, I just want put you in a table form, and just to make the thing simplified, so I just use the A, B, C, D, E, F and corresponding to the down below like a nutritional ricket, hypophosphatic rickets and so forth. So let's look at the A. Serum calcium is low, normal or low. Phosphate is low, normal to low. Alkaline phosphate is elevated. 25 hydroxy vitamin D is low. LPT, which is also slightly elevated. That will be your nutritional rickets. B. Serum calcium is normal. Serum phosphate is significantly low. However, alkaline phosphatase is high. 25 hydroxyvitamin is within normal range. PTH is normal to upper normal, or slightly elevated maybe. That will be your hypophosphatemic rickets. The things to remember here, alkaline phosphatase is the key in any form of ricket. It doesn't matter is a nutritional ricket or hypophosphatemia rickets or oncogenic rickets, alkaline phosphatase always will be elevated. It is a great marker. Absence of elevation of alkaline phosphatase will not suggest any kind of rickets. C is a low calcium, high phosphate, alkaline phosphatase low normal or slightly low, 25 hydroxyvitamin is low normal, and PTH is low. And this is clearly is hypoparathyroidism. Hypoparathyroidism. D, elevated serum calcium, low serum phosphate, slightly elevated alkaline phosphatase, 25 hydroxyvitamin D is normal, but PTH is significantly elevated. Obviously, this corresponds with the diagnosis of hyperparathyroidism. Hyperparathyroidism. E, the patient has low calcium and the phosphate level is slightly elevated. Alkaline phosphatase is normal. 25 hydroxyvitamin D is low normal and PTH is elevated. This is clearly a PTH resistant situation, and this is what we call pseudo hypoparathyroidism. Blood picture is exactly same like hypoparathyroidism. However, PTH is the one which is going to separate or differentiate this condition from true hypoparathyroidism to pseudo hypoparathyroidism. F, serum calcium is elevated, phosphate is still normal, alkaline phosphatase is normal, 25 hydroxyvitamin D is elevated, and PTH is suppressed or normal. That will be your vitamin D toxicity. Vitamin D toxicity. Which of the following is steps of vitamin D synthesis or the formation from inactive to active form is PTH dependent? We know the vitamin D comes from two sources, dietary sources and also from the skin, and from the dietary vitamin D goes to the liver with binding with fat or chylomicron, and from skin it comes through the vitamin D binding protein or binding with vitamin D binding protein comes to the liver. So in liver it goes to hydroxylation, 25 hydroxylase by enzyme 25 hydroxylase, which is step C here, and then it has to go to kidney to form the active form of vitamin D. In the liver, the product that we get is 25 hydroxyvitamin D, also known as calcidiol, and then in kidney with the action of 1 alpha hydroxylase 25 converted in 125 hydroxyvitamin D3 or what we call calcitriol, and that's the active form of vitamin D. Now, 1 alpha hydroxylase in the enzyme is PTH dependent. So if there is a significant PTH deficiency or excess, it's the 1 alpha hydroxylase is the one who is get involved. So PTH deficiency will result in low 1 alpha hydroxylase activity and therefore less production of active form of vitamin D. So the correct answer here is D. I thank you for attending this session. My next lecture will be on neonatal endocrine emergencies. Many of the causes of neonatal endocrine emergencies has been discussed, but this one will be the next discussion, the neonatal hypoglycemia.